Good day to Dr. Rafiq. We are from Group 7. Today, we will be introducing fibrous dysplasia, a rare but impactful disease that affects the human skeletal system with secondary effects on the muscular system as well. Our group members are Bayan, Kavita, Nuru Shahana, and Jackzi. Here are the contents that will be included in our presentation. I'm Bayan. To begin, let's start with an introduction to fibrous dysplasia. Fibrous dysplasia is a bone disorder where normal, healthy bone is gradually replaced by abnormal fibrous tissue, which is more like soft, scar-like material. As a result, the affected bone becomes weaker, more fragile, and often deformed. This condition can lead to a range of complications such as bone pain, fractures, uneven limb length, and even visible deformities, depending on the location and severity of the disease. The disease can be classified into two main types: monostotic fibrous dysplasia, where only one bone is affected, and polyostotic fibrous dysplasia, where multiple bones throughout the body are involved. Common sites include the femur, tibia, ribs, pelvis, skull, and facial bones. In some rare cases, fibrous dysplasia is also associated with McCune-Albright syndrome, a condition involving hormonal imbalance and skin pigmentation changes. Here are the examples of monostotic and polyostotic fibrous dysplasia. From a biological perspective, fibrous dysplasia is caused by a genetic mutation in the GNAS gene, which affects the development and function of bone-producing cells called osteoblasts. This mutation happens during early development and is not inherited. Because of this gene defect, the affected bones fail to form properly and are replaced by the fibrous tissue. Although this condition mainly affects the skeletal system, it has important consequences for the muscular system as well. When bone structure is abnormal, the biomechanics of the body are affected. This means that muscle attached to or surrounding the affected bone may have to compensate for changes in posture, uneven limb length, or joint instability. For example, if the femur is affected, the surrounding quadriceps and hamstring muscle may experience chronic strain or fatigue due to altered gait or imbalance. In the spine, paraspinal muscles might become overworked to support the curved or weakened vertebrae. Over time, this can lead to muscle pain, imbalance, or weakness, showing how fibrous dysplasia affects both parts of the musculoskeletal system. Understanding this disease is highly relevant to biomedical engineering because many patients require diagnostic imaging such as CT scans and MRI to detect the extent of bone damage and monitor disease progression. In more severe cases, patients may also need custom orthopedic implants, corrective surgery, or assistive devices like braces or orthotics to support affected limbs. These are all part of how biomedical engineers apply their knowledge of the musculoskeletal system to improve patient care and quality of life. That's all from me. Thank you.
To put it simply, fibrous dysplasia is caused by a gene mutation. The gene mutation occurs in the GNAS gene, which controls a protein involved in regulating bone growth. The mutation is not inherited, meaning it's not genetic, and it happens after conception. To further explain, the GNAS mutation leads to overactivity of the G protein signaling. This disrupts the normal development of the bone. As a result, normal bone is replaced with fibrous tissue. To put it in an analogy for us to understand, imagine you're building a house with bricks. Now you have to build it with soft noodles, leading to weak and deformed bones. Since the mutation happens randomly and really early on, there is no known prevention. It can affect a single bone, known as monostotic, or multiple bones, known as polyostotic. In this case, the mutation prevents proper maturation of the bone cells. Immature cells produce fibrous, as in scar like tissue, instead of solid bone. It overproduces the osteoblasts to the point that is very saturated and none of them can mature properly. And the timing of the mutation also determines its severity. If the mutation happens early on in the embryonic development, this would result more tissues to be affected, causing a polyostotic situation, as in more bones are affected. If it happens later on, maybe one bone is affected, which is in its monostotic form. In some cases, it can also be caused by McCune-Albright syndrome. To briefly go over McCune-Albright syndrome, it's very similar to regular fibrous dysplasia. However, the key difference being is that McCune-Albright syndrome takes it a step further, not just affecting bone, it affects bone, skin, and endocrinal system. The usual early signs of MAS is precocious puberty, which is early puberty, hypothyroidism, Cushing syndrome, and GH excess. This only affects about 2 to 3% of polyostotic cases, but almost always McCune-Albright syndrome is polyostotic. I like to go into the nitty-gritty of fibrous dysplasia because it is extremely interesting what happens here. So the red dot that we see on the picture is actually a G protein that has an alpha protein attached to it. So what happens is that this ligand that is shown here attaches itself to the GPCR signaling protein. So basically this protein tells us what to do and gives signals to the inside of the cell on what we have to do. The red dot goes and attaches itself to the active site of the GPCR, and then which activates the whole cell and activates it to change GDP to GTP. Basically, you need more energy, so I'm giving you more energy. And then it starts the whole process. This causes adenylate cyclase, which is an enzyme, to start producing C-AMP, which is also known as cyclic AMP. This is incredibly important for bone formation. In regular cases, this would happen, and then once the C-AMP is formed, it would go back and it would reverse, causing the GTP to go back into GDP after some of it is dissolved, some of the molecule as in is dissolved. However, when it comes to fibrous dysplasia, this does not happen. It does not dissolve or go back to how it was. It sort of is stuck. It's as though you turn a light on and the switch is jammed and you cannot find a way to turn it off. So it starts producing continuously.
Hello doctor, today I would like to explain about symptoms of fibrous dysplasia, which is a chronic bone disorder where normal bone is replaced by fibrous tissue leading to weak and deformed bone. First, we will look at common symptoms such as bone pain, where it causes dull, itchy pain and often chronic. Second is bone deformity, especially in long bones like the femur. Third is fracture due to weakened bones. Fourth is limb length discrepancy, where one leg or arm may be shorter. Last but not least is swelling or lumps, where bones are over-affected. Second, we will look at the symptoms based on the location, where when it's affected on facial bone, it causes facial swelling or asymmetry and sinus issue. When it's affected on skull base, it causes vision or hearing loss and headache. When it's come to long bones, it causes femur deformity limb, and when it's affected on ribs or spine, it will cause pain and breathing issue, which is a rare case. There is also symptoms on endocrine system, where it causes early puberty, skin pigmentation and hormonal imbalance such as thyroid and adrenal. Next, we move to diagnosis of fibrous dysplasia. There are many ways to diagnose this bone disorder. First is medical history and physical exam. From the symptoms, bone pain, fracture history and physical signs such as swelling, limb and asymmetry, we can diagnose this bone disorder. Second is genetic testing. GNAS gene mutation, which are somatic and non-inherited, often found in affected bone tissue. This is also one of the diagnoses for this disorder. Third is bone scintigraphy. It is basically bone scanning, where a radioactive tracer highlights area of increased bone turnover, which is helpful to locate multiple lesions such as polyostotic fibrous dysplasia and helpful in full skeletal mapping. Next, we will look at imaging studies. There are three types of imaging studies, which are X-ray, CT scan and MRI. X-ray is a ground glass appearance of bone, which is show the cortical thinning. CT scan is a detailed view of bone structure, which is best for skull and facial bones, shows the internal matrix of the lesion and the degree of bone thinning and also the expansion. It's really important for surgical planning. Next, we move to MRI. It's very useful if soft tissue involvement or nerve compression suspected. It shows the lesion replacing normal bone marrow. Next, we move to biopsy, which is confirmed benign fibrous tissue and rules out malignancy, which is a rare transformation into osteosarcoma.
Hello, my name is Tan Jack Zi, matrix number 24006138-1, and I will be presenting about treatment and prognosis of fibrous dysplasia. Fibrous dysplasia unfortunately has no known cure. However, treatment can significantly improve the quality of life for patients by managing symptoms and preventing complications. The main goals of treatments are to prevent and treat fractures, to correct bone deformities such as bowings when severe, to relieve chronic bone pain that often results from lesions and skeletal stress. To achieve these goals, clinicians rely on a combination of approaches. The three primary treatment categories include pharmacologic therapy, surgical intervention, physical therapy, and rehabilitation, while medication and physical therapy have supporting roles. This presentation focuses on surgical treatment. When fibrous dysplasia leads to significant bone deformity, instability, or frequent fractures, especially in weight-bearing bones like the femur or tibia, surgical intervention becomes necessary. The primary goals of surgery are to realign deformed bones, restore structural integrity, and prevent future fractures. Surgery also helps correct limb length discrepancy and improve mechanical function, especially in growing children or in severe polyostotic cases. Osteotomy is a surgical procedure in which the bone is intentionally cut and realigned to correct bone abnormal angulation or deformity caused by fibrous dysplasia. One of the most common deformities seen in FD is the Shepherd's crook deformity of the proximal femur. This occurs when the bone bends under mechanical stress, leading to big pain, poor mobility, and increased fracture risk. Osteotomy alone, however, may not be sufficient to maintain long-term correction. That's why it's often combined with intramedullary rod fixation. Intramedullary rod is a technique used to stabilize the bone from within by placing a metal rod through the medullary canal. This is important after an osteotomy to maintain proper alignment and prevent refracture. The rod helps distribute mechanical loads across the diaplastic, weakened bone, reducing stress on area most vulnerable to fracture. Is considered superior to plate fixation, especially in FD, because plate rely on screws that may loosen over time due to poor bone quality. This technique is commonly used in long bones like the femur or tibia and is often combined with osteotomy to correct deformity while also reinforcing the bone structurally. Surgical treatment provides durable benefits for patients with FD. First, it corrects bone alignment, which improves posture and walking mechanics. This is important in children where early correction prevents worsening deformities during growth. Second, it reduces the risk of refracture. Without proper stabilization, recurrence rate can reach 30%, but with rod fixation, that risk falls below 5%. Third, it supports long-term lesion control. While dysplastic bone may remain abnormal, surgical reinforcement slows recurrence and prevents structural collapse. Most importantly, surgery improves functional mobility with restored alignment and mechanical support. Patients often regain confidence and return to daily activities with fewer limitations. Biomedical engineering enhances the precision and success of surgical treatment in FD. First, 3D CT reconstruction and surgical planning tools allow surgeons to visualize the patient's anatomy in detail and pre-plan osteotomy angles, route length, and insertion paths. Next, finite element modeling is used to stimulate stress distribution in the bone before and after surgery. This helps identify high-risk areas where fractures or implants failures might occur, allowing the surgical team to make data-informed decisions. Finally, engineers can create custom implants that are specifically shaped to match curved or structurally atypical bones. Surgery is most effective when realignment and mechanical enhancement are combined. But it's engineering innovations like 3D imaging, finite element modeling, and custom implant design that evaluates the procedure from corrective to predictive and optimized for each individual. Prognosis in fibrous dysplasia varies significantly depending on three factors: the form of FD, the number of bones affected, and whether endocrine abnormalities are involved. Monostotic FD often stabilizes over time and needs minimal care. In contrast, polyostotic FD and McCune-Albright syndrome typically requires lifelong monitoring. Across all types, prognosis improves when we combine early treatment with engineering-guided monitoring like imaging, FEM, modeling, and personalized data dashboards. Let's explore how this looks across the three major subtypes. Monostotic FD affecting a single bone usually quiets down after skeletal maturity. Over 90% of patients maintain normal gait, and quality of life scores are often comparable to healthy individuals when pain is managed. Fracture risk is low, under 10% in most cases, though slightly higher if the femur or tibia is involved. Imaging is done yearly, typically with DXA or X-ray, and may shift to every 2 to 3 years after 5 years of lesion stability. Engineering tools enhance this light touch care. A one-time FEM stimulation on CT can flag weak zones. IMU-based gait sensors help track subtle asymmetries, and mobile pain logs feed into telehealth dashboards to flag flare-ups early. This shows how even low-risk cases can benefit from high-precision data-guided monitoring. Polyostotic FD affects multiple bones and often remain active well into adulthood. Lesions in weight-bearing bones like the femur, tibia, and pelvis drives a higher lifetime fracture risk, around 30% to 50%. Roughly 70% of patients maintain mobility, while others may need assistive devices, especially after repeated fractures. Imaging cadence increases here. Whole body MRI or CT every 1 to 2 years. Focus on high risk regions. Biochemical markers like ALP and P1NP are monitored every 6 to 12 months to catch disease activity spikes. From an engineering standpoint, FEM is used more frequently to model stress across curved or weakened bones, helping prioritize preventive surgeries. IMU sensors track stride symmetry and balance decline, often before patients notice symptoms. And telehealth dashboards integrate motion data, imaging, and labs for centralized tracking and proactive care planning. With consistent monitoring and engineering support, many patients avoid major complications. FD mass is the most complex form of the disease. Along with aggressive widespread lesions, patients face hormonal complications like early puberty, hyperthyroidism, and phosphate wasting disorders. Chronofacial involvement is common and can affect vision, bite alignment, and facial structure, sometimes requiring decompression or reshaping surgeries. Up to 50% of lesions stay active into adulthood, especially in the skull and pelvis. Hormonal treatment is critical. GnRH analogs slow precocious puberty. Phosphate and vitamin D supplementation address bone weakening. Engineering tools are deeply integrated here. Ano 3D CT and MRI help track optic nerve risk and post-op reshaping results. Bone turnover markers like FGF33, ALP, and CTX are tracked to coordinate endocrine and skeletal care. 3D printed guides allow surgeons to plan safer chronofacial surgeries. Gait sensors and motion tracking detect lower limb asymmetry common in severe cases. And all data feeds into a unified dashboard, letting endocrinologists, surgeons, and therapists manage the condition together. Despite lifelong challenges, around 60 to 70% of patients retain ambulatory function, proof of what's possible with integrated personalized care.
In conclusion, fibrous dysplasia is a debilitating bone disorder that causes pain and discomfort to all the patients that have them, especially without medical intervention. It is very important for us future biomedical engineers to come up with solutions in order to ease their pain and come up with solutions that are innovative and progressive. This project was done by the four of us, Bayan, Kavita, myself, Shana, and Tang Jekse. Thank you for watching, and this is Group 7.